Hi, everyone. I know folks are coming back from break, but I wanted to say hello. My name is Jen Lee. I'm the Deputy Director at the Association of Asian Pacific Community Health Organizations, otherwise known as APCHO. Welcome back from the break. I'm really excited to moderate today's panel session, which is called Parallel Strategies for Tuberculosis and Hepatitis B Screening, Testing, Treatment, and Maintenance. So we're covering a lot today. I am joined, as you've seen, by two amazing practitioners who are both champions and advocates in their own right, addressing TB and hepatitis B. So I'm going to go ahead and introduce them now so we can dive into the content. First, I'd like to introduce Dr. Nguyen, who's the director of the Hepatitis B program at Charles B. Wang Community Health Center in New York. She's involved in providing and updating hepatitis B protocols internally for OB and internal medicine departments, training internal medicine providers to care for hepatitis B patients, and advocating for viral hepatitis initiatives at the city and state government levels. She's been practicing as an internist for more than 10 years, providing primary care to underserved populations. She's committed to caring for the immigrant population with a special interest in hepatitis B. She's a graduate of Sophie Davis School of Biomedical Education at NYU Medical School, and she completed her primary care residency at NYU Langone Medical Center. Welcome, Dr. Nguyen. Our second speaker is Dr. Amy Shen Tang. She's a primary care internist and director of immigrant health at Northeast Medical Services, or NEMS for short, in the San Francisco Bay Area, where she oversees NEMS hepatitis B and tuberculosis elimination programs. She's the clinical principal investigator for the CDC TB Epidemiological Studies Consortium 3 at NEMS, and in collaboration with UCSF, the University of California, San Francisco, California Department of Public Health, and San Francisco Department of Public Health, covering everyone. And their focus is to develop cost-effective strategies for increasing TB testing and treatment in the primary care setting. She served as the co-chair of the National Task Force for Hepatitis B from 2017 to 2019 and received her medical degree from the University of California at San Francisco School of Medicine and completed her primary care internal medicine residency at NYU School of Medicine and Bellevue Hospital. So yay, welcome two amazing subject matter experts to today's session. Before we dive in, I just want to remind folks, and as we've seen throughout the summit, please use that comment box for any questions you may have. We'll try to answer them throughout, and then we're trying to leave a good portion of today's session for Q&A. So please don't hold back on any questions that you have. And with that, I will turn it over to Dr. Nguyen to kick us off.
Oh, thank you. Yeah. Hi, everyone. Thank you for having me today. I'm going to share my screen. Let me see if that works. Okay. Okay, here we go. All right, can you guys see the screen? Can you guys hear me?
Yes, I can hear you, Dr. Nguyen. Can't quite see your screen yet.
You don't see the screen yet, or you do?
We do not.
How about, let's see.
Thanks, folks, for chiming in there.
How about now?
Yes, there we go.
Okay, perfect. Okay, great. Okay, thank you. So yeah, I'm very excited to be here today and talking about the hepatitis B elimination strategies. Before I get into that, I would like to just acknowledge our sponsors. I want to thank them for making hepatitis B program happen at Charles B. Wang, and also I want to thank our team who works very hard for our patients through these many years. And then going into the agenda, we're going to talk a little bit about who we are and then about our screening and outreach efforts and our vaccinations, linkage to care, and then our future goals. So Charles B. Wang Community Health Center, for those of you who don't know who we are a federally qualified health center in New York City. We serve low-income Asian American community. We have the primary care specialties, our internal medicine, pediatric, OBGYN, mental health, social work, and dental in our clinic. And our Hep B program include the Hep B Mom program, which is for prevention of perinatal transmissions. And we have the care management for high-risk chronic Hep B patient, and we do have a free Hep B screening programs currently. So our strategy for screening for hepatitis B, we try to educate and remind our providers, mainly the internal medicine provider, about screening everyone for hepatitis B. So we give them updates about it, and we try to give them reminders frequently. And for all the new patients at our clinic, we would offer the hepatitis B screening. So it's universal screening for all the adult patients, because we feel that since we work with such a high prevalence population, this way we would catch everyone, and then we would eliminate the barriers and the stigma associated with hepatitis B. And also,
Hi, Dr. Nguyen.
yeah.
Sorry, it's Jen. We can't quite see if you're advancing your slides or not, so just wanted to check and see if that function was working for you.
Okay.
Oh, there you go.
Okay, so
yeah.
I think
you might have to click on it.
I'm just going to use this window. Okay, let me see. Got it. Okay, so so we think that the Hep B screening test is very low cost, that we can be included in routine blood test. It doesn't have to be a test that order alone, and so it's easily add on to other routine blood work, and it's easy for a patient to get it. And for the free screening for community members who are not outpatient, we do the free screening for anyone who wants to walk in and get that. And currently under the OMH grant, we are doing the free screening for contacts of people with chronic hepatitis B. And the reason we try to target this population, because when we did a study looking back at our patient population from 1997 to 2017, we found that the household contact of people with chronic Hep B, 49% of them would have prior infections, and about 22% actually has chronic hepatitis B also. So it's like a much higher rate than the general Asian American population. And also we start looking into offering screening for contacts of people who have previous infection, basically those who have core antibody positive, because we think that if they were contact of those patients, they also might be exposed to the same risk. And so I just want to show you how we keep track of the screening by the EMR. So we have this health maintenance form in the EMR where we put all the vaccination record along with screening tests and cancer screening. And so when provider open this up, they can see right away what needs to be done. And they can also click on this button under the order, and it's easily generate an order for them. And then on top of that, we also put all the hepatitis testing under the same panel, under the internal medicine lab. So that way it's easy for the provider to see, and it's remind them what to order also. For the Hep B mom programs, we have care management for the pregnant woman. So the care manager would run like a list to find out who are the newly pregnant women who have chronic hepatitis B, and they would try to meet with these women as soon as possible during the pregnancy to give them counseling about hepatitis B, and also to educate them about what to do to protect the baby. So they would give these women this chart that they can keep track throughout the pregnancy, and to check off, all different stages, and to make sure that they can advocate for their baby, that the baby would get the vaccination and also immunoglobulin at birth. And the care manager also continue to follow up with these women 1 year postpartum to make sure that they continue to get the care that they need. For community outreach, we work with community organizations in Flushing area and Chinatown area to do co-hosting of health events, so that we would reach out to a larger populations in the community. We also, going out and reach out to religious institutions and pharmacy, giving out information about our free screening program. And we also approach patients at the COVID vaccination site in our clinic. So during the time when they are they're being observed after they get vaccinated, then we would talk to them about hepatitis B. And the test comic book is something that developed a couple of years ago to explain more about what the tests mean and why people should be vaccinated. So this is what we give out to patients when we see them. And because of the pandemic, we actually start to reach out to patients through social media because we could not see them in person. It's difficult to hold community event and to do face-to-face meeting. So we start doing more posting on Facebook, on WeChat, Instagram. We post updates about general Hep B education messages. We post about free screening program, information about our program, and also any upcoming webinars. And the webinars and the radio show that we developed actually also because of the pandemic. And we try to continue to do education for patients. So we have radio show and webinar in Cantonese and in Mandarins, present the basic information about Hep B, and then also providing them contact information for screening. We provide free vaccinations for anyone who's acceptable and need vaccinations. And for this, we develop a protocol where the provider can order the initial vaccine series. And once the patient come in and get the first shot, then the nurse would automatically schedule them for the second and the third shot. And they would send out a reminder to patients to return to get the vaccine, so that way it's help improve the adherence rate for completing the series. And for those patients who need linkage to care but who are uninsured, we have about 9,000 patients in our Hep B registry, and approximately 3,000 are uninsured. So it's a large number, and so we accommodate them by having a sliding fee scale, so that it would lower the cost for them. And most of our patients, they also are mobile workers, meaning they work out of state, or and they rarely come back in New York, and sometimes it's difficult for them to get the care that they need. And so that's when care management also come in and help them with that. We work with local radiology centers also to help lower the cost of imaging study, to help these patients who are uninsured. And the same thing goes for like pharmacy. We have the patient assistance program for free medication, and we also have the 340B program with the pharmacy, so providing low cost medication for patients. So this is the Hep B flow sheet. So this is for patients who have chronic hepatitis B, and the provider can look at this and see what tests that need to be updated or to be done. And so it's a good way to put everything on one page and easy to keep track of. And also the one thing I think a lot of providers like is the liver cancer risk estimator. And we put this in here so that way, it's helped the provider with making decisions for some cases, regarding whether or not the patient needs to get the treatment. And this one is actually a kind of like a pocket chart where we give it to the patient, and we would update the information about the lab result, the screening test, and they can keep it with them and they can walk around with them. So, they understand what the condition is and also to see how it progressed. So it's a good way, kind of like to carrying around their own medical records. And so in the future, we do want to expand, universal screening to other departments in our primary care clinic, including the GYN, dental clinic. So we hope that, we can reach out to more patients that way. And we also want to work with more community organizations to do screening events if that's possible. And thank you very much. And if you have any questions, please feel free to, email me or Jane Wong, who is our program associate, and we'll be happy to answer any of your questions. Thank you.
Thanks so much, Dr. Nguyen. So helpful to hear a lot more about just what the health center is doing in New York around accessibility and affordability, just to increase access and reduce stigma. So I'm excited. If folks have more questions about that, please populate them in. And I will go ahead and transition it to Dr. Tang.
All right, can everyone see my slides?
Yep.
Okay, great. Thank you, Dr. Nguyen, for that great talk. I have a soft spot for Charles B. Wang. This is where I was working prior to coming at NEMS, and I see a lot of familiar faces in the virtual audience today, and looking forward to the discussion so we can speak again. So I'm covering our Hep B and TB programs at NEMS today, and I actually have a lot of content here, but I'm going to try to move through it as quickly as possible so we can have time for discussion and whatever questions you have. A little background about North Medical Services. We began serving patients in the San Francisco, Chinatown, North Beach community about 50 years ago in response to the lack of adequate healthcare services for uninsured and underprivileged Asians in San Francisco. And we've grown from this small primary care clinic in San Francisco, Chinatown to one of the largest community health centers in the U.S. serving medically underserved Asian Americans and other marginalized populations. We have 13 clinic locations across the San Francisco Bay Area, mostly in San Francisco, but also in Daly City and San Jose in the South Bay. Our services really cover a really huge spectrum. So beyond primary care, adult medicine, pediatrics, and OBGYN, we also have dental optometry. We have on-site pharmacy and lab and radiology, and also some other complementary alternative medicine services like chiropractic and acupuncture services, physical therapy, and also a lot of specialists that see patients as well a couple times a week. We serve about 65 to 70,000 patients each year, most who are Asian and limited English proficient, and majority who are Medi-Cal, which is California's Medicaid program. This is just the age distribution of our patient population, which tends to skew older than the city and state averages. In terms of the most common health conditions among our patient population, if you look at very common chronic diseases like diabetes and hypertension, our patient population has lower averages or lower rates compared to the U.S. averages. But if you look at things like latent TB infection and chronic Hep B, our prevalence is really quite high compared to the U.S. average. So our cumulative TB infection positivity numbers usually hover around 20 to maybe 25%, depending on your denominator, compared to about 5% for the U.S. average. And then for hepatitis B, our positivity rate among adults is 8% compared to 0.3 for the U.S. average. There's also a lot of overlap between our patients who have chronic hepatitis B and who are also infected with TB, and that's about 38% overlap. Our patient population in the Chinatown clinic, we see a lot of families and elderly individuals who live in single-room occupancy housing. And so these are dormitory-style units that have a shared bathroom and kitchen and are higher risk for communicable disease. And we've seen during the COVID pandemic that our patients who live in these buildings have higher risk of getting infected because of the nature and system, or the nature and the setup of their living situation, but they're also at higher risk of having TB infection, and we've seen that in our testing rates, higher TB test positivity compared to our average San Francisco population. San Francisco Bay Area is really a high TB incidence region. So for the United States, with 2.7 per 100,000 TB incidents compared to a higher rate of 5.3 for California. But if you look at the 3 counties where we have clinic locations, it's really the highest in California, even compared to Los Angeles. And the majority of TB cases in San Francisco are among persons who are born outside of the U.S., and about half of whom are born in Asia, countries that are well represented in our patient population, like China, Vietnam, Philippines, and India. We recognize that latent TB infection is a prevention opportunity to identify those who have infection and are not aware of it, and then to treat as many of these patients as possible. And so we have I have a schematic here of our LTBI care cascade, starting with the point of TB risk assessment and moving on to identification of those with positive TB tests, making sure that we also do our due diligence to screen people who might have active TB symptoms based on symptoms or abnormal chest imaging, and working closely with our Department of Health. And then also for those who are ruled out for any active TB disease, that we treat them within our own primary care setting with some of the preferred shorter TB regimens, like rifamycin-based regimens. Just last year, in November, we made the decision to start collecting place of birth. Before, we really only collected preferred language, and I know a lot of places don't collect place of birth, but this is something that we decided was important for our immigrant health programs, because a lot of the diseases that we are interested in identifying and treating, like Hep B and TB, really require that we know a risk factor like someone's place of birth. And so we started collecting this information last year for all new patients, but also all of our patients who are renewing annually their membership with NEMS. And we now have over 80% of place of birth information on our active patients. We've used this information to create a prompt for providers to complete the risk assessment if they haven't done that before, if they have a place of birth that is in a high-risk area. This is our TB risk assessment form. We've had a version of this in place for the last 10 years, but we recently simplified it with fewer questions to match the state-level TB risk assessment. It also includes information like prior TB testing and treatment, or prior active disease and treatment. And then on the right-hand side has their any recent imaging and TB test results to review history when we make decisions on whether to order a test or not. We also send notification letters to patients who have a QuantiFERON TB blood test ordered, whether it's abnormal or normal. And this has been actually very helpful for patients to make sure that they follow up with providers if it's abnormal, just in case they are lost to follow up in some way, or the provider has other priorities and forgets to address the positive test. This has been a good way to empower patients to follow up on their positive testing. We also wanted a way to standardize treatment discussions to adequately document if a patient refused treatment after discussion of risks and benefits, and also a way to document completed treatment after someone's finished LTBI treatment, or if they mentioned that they had already taken treatment in the past. So whatever's entered into this treatment template, which is linked into the assessment and plan section, actually goes into their chronic medical problems history. We also have a provider report card for latent TB, which gives providers feedback on their TB testing and treatment completion or treatment prescriptions for those who tested positive. We actually divided up patients into high and medium priority groups based off of age less than 50 and smoking and diabetes status, as in the past these were identified as higher priority patients to get treatment because of higher risk of TB reactivation. Almost every year we also have a talk with our local Department of Health on LTBI, and so last year our TB director gave a talk on the most recent CDC LTBI treatment guidelines that came out, and discussing some of the preferred rifamycin treatments. And this is, I think it's actually had quite a effect on increasing our shorter course regimens. This is a really useful one pager that we give to providers, like a flow diagram or algorithm for especially new providers to use who maybe weren't as experienced with TB testing and treatment. This is created by our California Department of Health and something that we provide to new providers. We also have some slides in our waiting room televisions that rotate, so patients can see some of the messaging that's come out from TB Free California. And And this has been, I think, on our waiting room slides for the last year now. This is a TB care cascade for 2019, so our last normal year before the pandemic, but it's really just to show that, despite all of these different interventions that I just discussed, there's still a lot more work for us to do. For our total patient population, the majority, about 90% of patients seen that year in adult medicine were non-US born, but only 39% had prior TB testing. 61% actually didn't have any TB testing even at baseline. And that year we only tested 16% patients for TB who hadn't had a prior test, and just kind of going through the whole care cascade. 56% of those who identified as positive were treated, and mostly with shorter rifamycin regimens. This is over the years, the last decade. You see a big drop off with 2020, of course, because of the COVID pandemic, but you do see that with some of the interventions that we've rolled out over the years, there has been an increase in TB testing, and then a trend towards using the blood test, the QuantiFERON, or over the skin test. And in terms of TB treatment, you also do just see a general increase over the years. However, there was a drop-off in 2019, even before the pandemic. And this is something that we're kind of looking into, some strategies to kind of sustain or maintain some of the improvements that we've made over the years. We have, a lot of strong TB partnerships, especially with public health on the state level and local level. And then, of course, most recently with the TB Elimination Alliance that started last year, and APCHO. But we, as I think mentioned in the introduction, we recently got the TB Epi Studies Consortium grant, which is a 5-year grant to partner with UCSF and look at cost-effective strategies for increasing TB testing and treatment in the primary care setting. Now, I want to talk about Hep B as well. I want to leave time for discussion, so I'm just going to skim over this, that we have a really high burden of Hep B at NEMS, both among non-pregnant adults, but also pregnant adults. About 1 in 4 pregnant women in San Francisco actually get their prenatal care at NEMS. This is data showing that California actually has the highest burden of Hep B-related liver cancer in the U.S., and the San Francisco Bay Area has the highest prevalence of hepatitis B in all the state of California. And these are just some of the numbers in some of the counties that we serve. This is just sort of a layout of all the different elements of our Hep B program. We decided last year to screen all adult patients at NEMS for Hep B and C. For C, there's already a U.S. Preventive Task Force recommendation to screen all adults. And for B, we just reasoned that the majority of our patients are foreign-born, and even if they weren't in that category, it would be an opportunity to vaccinate if we saw someone who's susceptible. We have these prompts in our system to do B and C screening to remind providers if they haven't done so at baseline for those who are 18 to 79 years old. We provide Hep B vaccination, including the 2-dose Heplisav for non-pregnant adults. We have the 3-dose, and then, of course, we focus on making sure all of the infants are completely vaccinated, and a focus on the infants born to Hep B moms as well. We started a Hep B Moms program last year, really modeling after Charles B. Wong's Hep B Moms program. So we have a care coordinator, and we have Hep B provider champions in each department, and also at our major sites that have prenatal care. And so for these provider champions at each of the major sites, they're actually adult medicine providers that have been specially trained to treat Hep B during pregnancy, so starting antiviral for women who have high viral loads to make sure that we reduce their risk of transmission to the baby down to 0. We created a Hep B Moms roadmap last year. Again, this is really modeling after the Charles B. Wong program that was so successful. We have our own Hep B registry, about 7,000 patients, about half who are active and have seen us in the last 1 or 2 years, about 60 pregnant patients that we follow every year through Hep B Moms. But you see that the majority of our patients are in this age group that is really at high risk for liver cancer. So our highest most of our patients are in their 40s and 50s and also in their 60s and 70s. And so that's why we really try to make sure that everyone is coming and getting their labs done at least every year, if not every 6 months. And that also that we do appropriate liver fibrosis staging. So just last year, we started a FibroScan or liver fibrosis staging program. We purchased a FibroScan machine. This is something we usually in the past had to refer out to specialty centers like big hospitals, UCSF, CPMC, but now we put it in-house. We are able to provide this service to all Hep B patients, Hep C patients, and then also anyone that we suspect fatty liver and a lot of our diabetes patients who have elevated liver enzymes, and we want to really kind of stage the amount of fatty liver and if they have any fibrosis. This is a handout that we created so that we could explain to our patients, in this instance in Chinese, about what their scores mean. We also have a liver cancer surveillance program. So as I mentioned, we have radiology in-house and we provide liver ultrasounds. They started using this scoring system called LIRADS. And some of you who are in the medical setting, work in the medical setting, may be familiar with BI-RADS for breast cancer screening or TI-RADS for thyroid or lung RADS for lung cancer screening. So it gives you a score from 1 to 3, 1 being negative, normal, and 3 being, something that needs further imaging like an MRI or CT to kind of look into further and make sure that it's not liver cancer. I think this scoring system has been really helpful to standardize follow-up, and this is something that we're actually trying to build further to make sure that everyone is getting appropriate screening at the appropriate intervals. We reference, when we train our providers at NEMS, we reference the Hep B guidance for primary care providers that was published also last year. This is by a special work group that was put together when I was involved in the task force, the national task force. And I think it provides a more simplified version that PCPs can follow rather than referencing the 70 plus page AASLD, very detailed and useful recommendations, but not as user friendly for the primary care setting. We're also involved in advocacy, and many of you may have heard that California recently passed this law for Hep B and C screening and referral to care that really requires primary care health settings to do appropriate Hep B and C testing and management. So where we fall short on things, we're trying to improve our liver cancer surveillance ultrasounds with different prompts to make sure providers are ordering them. We may be doing standing orders that our care navigators can start using, and result letters to patients. Sometimes our patients with Hep B and C may get referred out for care and then lost to follow-up. So we're trying to really train all of our PCPs to feel comfortable with the management so that they can be managed in-house. It's always a struggle to do the household contact screening that's recommended, but it's a very important aspect of TB care. So this is something we're going to try to focus on more as well. And then with Hep B vaccination, we're really hoping that ACIP passes the universal adult vaccination recommendation so that we can follow suit and do a better job with vaccinations as well. And there's a lot of partners that we work with, and some of you may already know that we are participating in the Hep B ECHO, out of SF Hep B Free, but in partnership with Asian Health Services, and Asian Liver Center, and NEMS, and of course Hep United and APCHO. So thank you very much, and I hope we have enough time for questions.
Thanks so much, Dr. Tang. We definitely do. I think it looks like we have a good 15 minutes remaining for Q&A. Thank you both so much. That was incredible. There's a lot of accolades in the comment section about just the models you all have put forward and so many of these tools and the policy opportunities to continue to work within this network and spread all the good work. And want to get to a few of the questions that came in. You may see them there, but for Dr. Tang, Thaddeus had asked, it's amazing that NEMS was able to collect place of birth. He wanted to ask, was there any hesitation from patients in collecting that information?
Yeah, that was something we were wondering, we were worried about. I think that maybe other people haven't followed suit because they are worried that, especially in an immigrant population, that people may feel threatened in some way. But our member services department, which is really like the frontline department that works with new patients, or really all of our patients every year, they ask a lot of sensitive questions when they register patients, including their we talk about SOGI data, and that's collected up front as well. And I feel like that's kind of a sensitive area for people as well. We collect we collect income information so we can put them on the appropriate sliding scale, tax documents, those types of things. And so we actually haven't found that it's been an issue or a sensitive topic. I actually, for some reason, and I actually remember this when I was at Charles B. Wang too, we had already been collecting year of entry into the US. And I'm not sure the history of why that was collected, but it sounds like even before we were kind of collecting information of whether they were US born or not, but now that we're starting to collect more specific information on place of birth. And so, yeah, it hasn't been an issue since we've started.
Great. I think there was a follow-up, Dr. Tang, just to ask if you might be able to share the one pager that you're working with on providers on TB screening. Folks really love that tool, so we can follow up and send that to everybody. Let's see, Richard. Yeah, just commenting on the birthplace data collection in Houston. Have a similar population been asking for place of birth. We encountered little resistance. Again, as Dr. Tang said, it's how it's asked. There's so much training on the front end. Let's see. I think for Dr. Tang, a question from Farah. Would you be able to discuss modifications to the EHR, for example, the TB risk assessment?
Yeah. So this is something that we're actually going to be looking into for this TB Epi Studies Consortium, because we've actually reviewed recent data that TB risk assessment is it's not highly utilized. I think as a provider, anytime you have to fill out a separate template to get something done, you try to avoid it as much as possible because everyone is very busy. And, this model of TB risk assessment, it's very different from, let's say, Hep B screening, right? Like Hep B screening, you rely on a provider to know what the screening criteria are. So if you work at a place like NEMS or Charles B. Wang, and you see a lot of patients who are born in Asia, you just kind of reflexively know, okay, I have to order a TB test or a Hep B test. I also, should order a TB test as well. So we found that for all of the patients who had TB test ordered, I think it was only about 16% had a TB risk assessment associated with that order, which tells us that providers are just ordering the TB test without even filling out the risk assessment. And this is something that we may need to be kind of more radical and think about. Should we even continue using this risk assessment if the utilization is so low? But conventional standard recommendations are use the TB risk assessment because you have to ask if there are any new risk factors like close contact with TB or new immunosuppression, or if they traveled outside the country. But really the lowest hanging fruit is to get our foreign-born patients a baseline TB test. And because from our data, we showed that more than half of our patients haven't even had that baseline test, maybe we need to take a more simplified approach. So I guess the question was originally about EHR modifications, but the risk assessment is something that we are going to seriously look at and consider whether we need to do something radical to change provider behavior, because the way that it's written out now, it's just a lot of extra steps, and it doesn't maybe match the way that providers think about these things.
That's really helpful. Speaking of changes and workflows and everything, I think one question I had was, how do the changes in clinical guidelines for screening play a role, impact each of your organization's screening protocols? I think we know that the hepatitis B guidelines are soon to be updated. I'm wondering if Dr. Nguyen, if you could share like what steps you take once you have adjustments in the guidelines within your existing programs and workflows. Oh, I think you're still muted there. Very good.
Okay, so for us, we are already doing universal screening for our patients, and we would love for the guideline to kind of recommend that to, so that way we can be able to screen more people without having to do the long-winded risk assessment, which, like Amy said before, that most providers in clinical practice would probably want to avoid. So anything that have to do with like answering questionnaires and risk assessment, they definitely need to be avoided. And then on top of that, it would help us create protocols better. So when you do more like a universal protocol that apply, that could be carried out without having a clinician involved in every single stage of decision making, it would make it easier for the patient to get all these care, with better follow up, with better reminder. So I think that would be really helpful in terms of having more people getting like the standardized protocol.
That's really helpful. Both of you kind of alluded to this just with the increase in social media outreach and, even the telehealth visits, the changes that have resulted from COVID. And just wondering, how has the COVID environment affected your screening and follow-up efforts? And have you added anything new that maybe we should look to as a gold standard?
I think that what happened for NEMS when San Francisco locked down in March, we hadn't done any telemedicine before, but I remember one of the first things that I did myself, because we just didn't know where to start. Like, do we just start calling patients? Or, I ended up grabbing a list from our HEPI registry of patients who had high viral loads and high liver enzymes. And I just went through the list and started calling patients who hadn't had any labs or follow-up in a while. And that was an interesting approach because I had kind of just started NEMS fairly recently when the pandemic had started, and ended up starting quite a few patients on medication. It's interesting to kind of go through, because hepatitis B really can be managed more remotely just by getting the lab data. There isn't often a lot of physical exam components that need to be done unless someone already has advanced stage liver cirrhosis. So it was interesting to kind of do this population management, population health approach using large data sets where you can really identify people who are high risk or who have been lost to follow-up, haven't had labs for a while, and re-engaging them into care through telemedicine and really systematically identifying those people instead of waiting for them to come to you. And so in the last year and a half, since the pandemic started, since that kind of random intervention that was done when we locked down, we have started doing care navigator outreach to these patients to get them in for labs or their liver ultrasounds and to follow up with their providers. And so we're starting to take more of this population health approach because it does match well with our current telemedicine infrastructure. Patients, it's pretty low barrier. Like, they don't have to come in for this. They can just go get the labs done, go get the ultrasound done, and follow up by video or phone. And I think that those changes and being able to provide that care have been helpful.
Yeah, I agree with Amy. I think that because of the pandemic and exploring the option of televisits has actually been helpful for the patients, especially a lot of our patients, they either living out of state or they actually work out of state. And so for them to come in is difficult. And so one thing, because we have the Hep B care program with the care managers already on site, they were able to just kind of pivot toward doing more televisit counseling with the patient, and they continue to help the patient with getting the medications from the patient assistance program, and also to make sure that they're getting the lab test done, either coming back to the the site to do the lab work or even where they live, and to kind of sending the lab requisition over there and getting them to do it. And so keeping them engaged, basically. But I think the one thing that we found really important is to make sure that even if they don't come in or not getting the lab test done on time, that they continue to get the medications, to prevent the hepatitis flare. So it's opened up a new channel for patient, and I think it should be something that continue moving forward, just to lower the barrier of care.
Definitely.
I do want to mention something about TB. So I mentioned we have single room occupancy buildings around our Chinatown site, and they have been a hotspot for some COVID outbreaks. And so we are actually working with the TB, the San Francisco Department of Health, the TB control division, to adopt a similar model for doing more TB testing in buildings that either have positive TB disease cases or maybe like what we call TB seroconversion cases. So those who were previously negative and then tested positive. We think that these models for TB and COVID are very similar because they're both very communicable diseases, and also for our patient population, especially these SRO buildings in Chinatown, it's really a good opportunity to use some of these really innovative strategies that we started during COVID, and then move forward on thinking about how to increase TB testing and treatment in these buildings as well.
Great. One more question. I think I think we're looking to both of your organizations as sort of leaders in this work for sure. And if there is kind of a gold standard that you would want to put forward in terms of aiming for parallel strategies for Hep B and TB, I heard a few things, but what would be some key ingredients in that? I know both of you mentioned just the tools and the capacity within the electronic health record that you're using, the community partnerships piece, the on-site radiology, pieces for the health center. But are there things that you see emerging that we should all be considering advocating for or adding to existing health centers or health providers in the work?
I would say that collecting place of birth is, I think, a good step, because both TB and Hep B are dependent on whether they were born or resided in a place of high endemicity. And even though our health centers generally just screen everyone, I think this is data that is useful. You can use it in your EHR to help alert providers if information is missing. Provider education is really key. Like, I think that there are often updates to recommendations. For example, LTBI, like when I was in training, the main treatment was isoniazid, which is a medication that unfortunately we see a lot of liver toxicity. And once you see that once in one of your patients, I think providers feel reluctant to recommend treatment to all of their patients, just knowing what the potential side effects are. But with the new shorter course rifamycin regimens, it's much less common. And I think seeing a lot of patients successfully treated with these shorter new preferred regimens will boost their confidence and their recommendations to patients moving forward for LTBI treatment. It's also for the overlap in patients who have both chronic Hep B and TB infection. There was a lot of reluctance to treat these patients in the past because they already have liver disease, and we were worried about liver toxicity with TB treatment medications. But now with the newer regimens, this is not as big of an issue. And, there are some things to take into consideration, like rifampin and patients on TAF, on tenofovir alafenamide. But there are easy modifications to be made. And so I think that thinking about the two conditions and where they overlap, it's definitely doable, but there is a big provider education piece that needs to be done, I think, regularly, like every year.
I think for hepatitis B, Charles B. Wang is definitely to continue to provide educations about Hep B for providers, especially new provider who just starting out and basically learning how to manage Hep B right off the bat. So it's important to kind of give them that comfort, and also keep everything simplified. I think simplification with the EMR support is really important to continue to keep up with the standard of care. I think a lot of the time now the provider is relying on that to help, giving them reminder, giving them support, keep up with all the new updates and guidelines.
It's really helpful advice. We are right at the top of the hour, so I may have to transition us to close out this session. But I want to thank both Dr. Tang and Dr. Nguyen for your time and all this amazing information and expertise shared today. I want to encourage folks to please connect over the platform. I saw some great starter conversations there too. So thank you all so much for joining this session, and thank you, Dr. Tang and Dr. Nguyen. And I think we're going to conclude and hopefully see you at the closing session, which is next. Thanks so much, everyone.
Thank you for having us. Thank you.
Thank you.
Thank you so much, Dr. Tang. Thank you so much, Dr. Nguyen. And thank you, Jen. That was such an amazing panel. We are now transitioning to our closing session, and I believe it's here. No one has to, I think, leave the room, I think. So Dr. Tang and Dr. Nguyen, you're welcome to click the mute and camera button if you want to disappear from the screen, or you can stay on and join us. So great. Okay, folks. So we are now, we have now reached the closing session of our virtual summit. For those who have joined in the middle of the summit, welcome, welcome. Thank you so much for participating in our first ever joint virtual summit hosted by Hep United and TB Elimination Alliance. So I just want to ask folks a quick question. What do you think of our virtual conference so far? Feel free to click on any of the emoji buttons at the bottom of your screen, or chat in the comment box. I see Timur's comment. I thought it was great. I see a lot of emoji claps and inspiration buttons and laughing emojis, I think. Dr. Fayette Truck says the platform is easy to navigate around. Oh, thank goodness. That is music to our ears. Megan says that they love the tech functionality. Richard says great conference, learning a lot. Ben says excellent, fantastic, fabulous. Thank you so much for that wonderful feedback. We are just so grateful for everyone's time and energy here. I would like to thank everyone for their active engagement in all of the panels and workshops. We highly appreciate all of the comments in the comment boxes and the one-on-one direct message chats that we're seeing through the virtual platform. We certainly encourage you to talk to each other more through this virtual platform today and tomorrow. For our closing session here, I'm thrilled to introduce everyone to the amazing Dr. Sue Wang, who serves as the president of the World Hepatitis Alliance and is the medical director of the Center for Asian Health at St. Barnabas Medical Center. She has an amazing bio, which I'm going to copy and paste into the chat box for you all to read. And Dr. Sue Wang, thank you so much for joining us. I'm going to turn the invisible microphone over to you so that you could close us out today.
Great. Thanks, Joe. Really nice to be here. You guys can hear me okay?
Yes, we can hear you perfectly.
I've had technical issues all day, and so I had to race from the office back home so I could escape the hospital firewall, which did not like this platform for some reason. But it's an excellent platform. I have to say this is one of the best that I've seen, probably one of the most interactive. So kudos to you guys for using this. All right. Well, thanks, Joe. I want to acknowledge everybody who's been here. All of the great community health leaders, researchers, and clinicians who took the time to share their important work on Hep B and tuberculosis elimination in communities all across the continental U.S., Hawaii, the U.S. territories, and the freely associated states. I want to go back and thank the first speakers of the panel, Becky Nguyen, Chen-Chi Huang, and Jamie Carrillo, for sharing your innovative pilots, your impactful programs, and effective community engagement practices, especially while navigating the COVID-19 pandemic. It was really helpful to hear all those experiences. Next, I want to thank our workshop speakers, Dr. Amit Chitnis, Dr. Robert Wong, Kenson Alec, and Melissa Lalonde, for sharing your research efforts about how data can be leveraged and highlighting how we strengthen our approach in hepatitis and TB screening and testing in Pacific Islander communities throughout cross-sector partnerships. I learned a lot from those. And I'll probably be tapping Dr. Wong and Dr. Chitnis about their projects afterwards. And then finally, I want to thank Dr. Amy Tang and Dr. Yuan Nguyen for helping us all identify parallel strategies to eliminate Hep B and TB. Thanks for sharing your Hep B and TB innovations and remarkable advancements made in FQHCs, and to share how FQHCs really can serve as important healthcare partners to advance equity. And of course, I love being on stage with these two doctors because I was at Charles B. Wang Community Health Center as director of the Hep B programs from 2006 to 2013, developing many of these programs in their infancy. So it's really amazing to see what these doctors have done to grow these efforts. I think it's just a testament to how we are a close-knit community here, and you never know where somebody will end up, and how we all of us stay kind of doing this kind of work. So I want to close finally with a reflection on the theme for the summit, which is centering community to advance health equity. Centering community to advance health equity. And I really love this theme. I think it just highlights the really important things that are going to get us to elimination. So just as background, I'm an internal medicine physician. I now run a Center for Asian Health in New Jersey. I'm somebody living with Hep B myself, and I am currently serving as the president of the World Hepatitis Alliance. As Joe mentioned, we are a global NGO, and our mission is to harness the power of people living with viral hepatitis to achieve hepatitis elimination. And that really brings up so many of these issues that you all have mentioned today. And this theme of centering community in order to advance health equity really highlights two critical things that are going to get us to both viral hepatitis and TB elimination, and that's community and health equity. It's clear with both of these diseases, Hep B and TB, it's not that we don't have the tools already for elimination. We have great scientific knowledge about both Hep B and TB. We know what the sources of transmission, how they're transmitted, how the disease progresses. We know what the clinical symptoms are, how they affect the body, and what the complications and sequelae are. We also have really excellent diagnostics for diagnosing people and following them throughout their course. We have treatments that work in eradicating Mycoplasma tuberculosis bacteria, both active and latent infections. We also have very safe, effective meds that suppress the Hep B virus to prevent cirrhosis and liver cancer. And there are exciting curative therapies in development for Hep B. But the problem is these tools aren't accessible to everyone. Many of those who are at high risk for these infections don't have good access to healthcare. You guys all know this very intimately. And they face many barriers. And so we see large health disparities. And it's really this health inequity that is the main barrier to getting us to elimination. The WHO recognizes this, that if we don't address the factors that lead to health inequity, we will not get to elimination. Health equity is actually an important focus that the WHO has been focusing on in their draft Global Health Sector Strategy, the GHSS. They're in the middle of drafting this. It's in development, and it will be a 2022 to 2030 version that will be released next year. And there's a real big focus here on integration of services into primary care, universal health care, and also on community strategies in order to reach those most at risk. So this really leads us to talking about the importance of community. And that's you all. You all working in the community know the population at risk for both of these conditions. You work amongst the community, you serve the affected populations, and many of us identify with these populations. We come from the community. And we see that people who are embedded in the community are really the ones who can truly reach those at risk and who are affected by both of these conditions. Those of you doing this work, you don't silo people by disease. You seek to help the whole person, and you understand what person-centered care looks like. You don't just deliver TB or hepatitis services. You also have been delivering COVID testing, COVID vaccines in the midst of this pandemic, amongst myriad of other important services that people need. The point is, you care about the community. It's clear that data and tests and cures are not enough. We've had so much knowledge about TB and hepatitis, and people are still suffering from both of these. It's not about the head, it's about the heart. It's about understanding and caring for the community and meeting them where they are at. And this is what makes community initiatives like what you are all doing successful. So I just want to make sure everyone realizes how important this work is that you all are doing and encourage you to keep going. This summit has always been such an important meeting for encouraging and inspiring each other and getting a chance to network. And I just want to give a huge kudos and shout out to APCHO and HEPI Foundation and everyone who's been a part of the planning and execution of this meeting. So thank you all for bringing us all together. And I really hope we can all meet in person next year. Back to you, Joe.
Thank you, Dr. Siu-Wang. Couldn't agree more. I really look forward to the day when all of us can get together in person. You're receiving a lot of emoji claps, so yes, round of applause for Dr. Siu-Wang's closing comments. Thank you so much for your wise words. I have a couple of announcements. One, I just want to let folks know that tomorrow will be our last day of the HEPI United and TB Elimination Virtual, TB Elimination Alliance Virtual Summit. And we have a really exciting agenda for you all. So starting at the same start time tomorrow, that is 1:30 p.m. Eastern, we will be reopening our poster and exhibitor sessions. I would like to take a moment and thank all of our presenters for sharing their great work. Throughout the day, we will have a packed agenda. First, we will have a panel focused on lived experiences, where panelists will describe their lived experiences with HEPI and TB and reflect on their experiences as patients, including challenges and recommendations for quality care. For tomorrow's workshops, we will learn about how the COVID-19 pandemic has impacted our ability to eliminate HEPI and TB from both a clinical and patient perspective, and how we can mobilize communities to improve HEPI and TB policies to advance health equity. And lastly, at the end for our closing panel tomorrow, we are incredibly excited to host Dr. Carolyn Wester, Director of the Division of Viral Hepatitis, and Dr. Philip Lebu, the Director of the Division of TB Elimination. Both Doctors Wester and Lebu will talk about how we can overcome challenges together to eliminate both HEPI and TB. So we certainly invite everyone there to and to come prepared with any questions. I want to close with two quotes and lessons that I found to be incredibly inspiring from our speakers earlier today. One of them is Becky Nguyen from the Vietnamese American Cancer Foundation. She mentioned on the panel earlier that successful hepatitis outreach and education, screening, testing, and treatment requires strong care coordination efforts and deep engagement with our local communities. And this entails patience, flexibility, creativity, and empathy. So thank you, Becky, for sharing those invaluable insights with us all. And another lesson I learned from Melissa Leylon from the Arkansas Coalition of Marshallese mentioned in one of the workshops earlier that TB screening, testing, and preventative treatment can be accomplished in hard-to-reach communities that do not have access, or especially communities that face structural barriers. And this is possible through cross-sector partnerships between community-based organizations, community clinics, and state and local public health departments. So I just found those lessons to be really valuable. Thank you for your emoji claps. With that said, I just want to close today's virtual summit. It is 5:15 Eastern. We are ending on time. So thank you all for your participation, and we'll see you tomorrow. Thank you, everyone. Take care.